Today's topic is children's mental health, how to break down stigmas and eliminate the barriers to support and treatment. With 50% of all lifetime mental illnesses starting at age 14, and 1 in 5 children having an untreated, significantly impairing mental health disorder, these conversations are necessary now more than ever. On our sleeves is the movement to transform children's mental health, which is backed by the experts at Nationwide Children's Hospital, 3 of which we have here today. Nationwide Children's Hospital is one of the largest pediatric hospitals and research networks in the country. Our aim today is to raise awareness, to provide a forum to discuss this important topic with 3 very special guests, to share resources and local community connections. And really, in many ways, what I think is most important is to consider tangible ways we can work together to impact our community in a beneficial way as it relates to children's mental health. I just want to say generally, this is a very informal presentation. We have certainly many questions to cover with the panelists, but really the intention is to provide this as an opportunity for the community to have a connection point. It's not often that you get 3 acclaimed Nationwide Children's Hospital physicians on the line to just pick their brain and have a one-on-one discussion with. So really, more than anything, at Healthy New Albany, we want to provide this opportunity for connections. So please, in the chat, if you have questions, type them in. I'm watching them, we have others watching them. We will filter them into the conversation and take time at the end to cover them. So please do engage this conversation. It's not at all formal. We want to have the opportunity for everyone to connect and discuss. So please use the chat. Without further ado, I would like to introduce our esteemed panel of experts here today to discuss this important topic. First, Dr. Mike Flores is a clinical psychologist and clinical coordinator at the Downtown Outpatient Therapy Team with Big Lots Behavioral Health Services at Nationwide Children's Hospital. He provides clinical and administrative oversight over a disciplinary team of social workers, counselors, and psychologists who treat a wide array of mental health conditions in children aged 3 to 18. In addition to his administrative role, Dr. Flores continues to see a small caseload of patients and serves as a clinical supervisor to psychology and psychiatric trainees. Dr. Flores' clinical and research interests include assessment and treatment of disruptive behavior disorders and ADHD, the role of screen time on children's development, and improving access to equitable health care for underserved or underrepresented populations. Could you just give us a wave, Dr. Flores, so we see you? You might have to unmute and say hello.
Hello, it's a pleasure to be here. Thank you.
Thank you for being here. Next is Dr. Ariana Hoet. She is a clinical assistant and professor of pediatrics in the Department of Pediatric Psychology and Neuropsychology at Nationwide Children's Hospital. She has a Bachelor of Science in Psychology from The Ohio State University and a PhD in clinical psychology from the University of North Carolina, Greensboro. Dr. Hoet currently works in pediatric primary care at NCH, where she serves primarily Latino and Somali immigrant population at Westside Primary Care. She is also involved in Latino community efforts, both personally and as a professional, and she herself is an immigrant from Venezuela. Could you say hello, Dr. Hoet?
Hi, everyone. Thanks for having us today.
Thank you. On our sleeves, clinical director is Dr. Parker Houston, PhD. He's a licensed clinical psychologist and clinical director of the On Our Sleeves program at Nationwide Children's Hospital. In his role with the On Our Sleeves movement, Dr. Houston works on population mental health initiatives. He develops, manages, and shares mental health content and advocates for children's mental health on a local, regional, and national level. He also provides education and programming to families, schools, and companies on how to discuss mental health and improve mental wellness and access to services in their community. Dr. Houston's passion is rooted in providing education and opening doors so that children and their families can achieve their maximum potential. Focusing on good mental health practices during childhood can create healthy habits throughout a lifespan. Could you say hello?
Hi, everyone. Thanks for being here.
Thank you. So to start us off, we wanted to ask just a couple general questions. And Dr. Houston, we would ask for you first to provide us an introduction of the On Our Sleeves program and how this was influenced by the clinical work here in Central Ohio.
Absolutely. On Our Sleeves is a concept that came up, at least 4 years ago, if not 5 years ago now. And as the Children's Hospital as a whole was coming up with a strategic plan, that it's a 5-year plan, mental and behavioral health became a significant focus and something that they wanted to grow substantially in that time period. And so in addition to improving services and increasing the service line in general, which is now, as far as we know, it's the largest children's behavioral health service in the entire country here at the hospital. They also wanted to think about how could we affect change in the community? How could we bring information about children's mental health out into the community? And so On Our Sleeves was officially born on October 10th of 2018 with the initial mission of breaking stigmas related to children's mental health and making it a more acceptable topic of conversation, something that, parents could seek help for without feeling negative connotations with that and things like that. What it's grown into since then is we still are focused on breaking stigmas related to children's mental health. But what we found was that initially every talk that someone would give or every presentation they would make, the inevitable question at the end was, wow, now that I know all of this, what do I do? How can I help? How can I help my kids? How can I help people in my community? I'm a teacher. How do I help my students? I'm an after school program coordinator. How do I infuse this into our curriculum? And so I was able to join as the clinical director last year, and we've really changed our focus to not only breaking stigmas, but trying to create a mental wellness curriculum. And so we first educate people about the importance of children's mental health. We're doing that today, hopefully. But then we also move on to different ways in which we can impact children and their mental health. And, Dr. Hoet and Dr. Flores are really excellent providers when it comes to, thinking of children who need assistance and need services. My focus is really on getting to them as early as possible in the community where they live. And how do we provide evidence-based activities and structured things for teachers to do so that we can improve the mental wellness capability and the knowledge that kids have. And so we teach all kinds of different things, some of which we'll go over today, but that's really grown to be our focus. And it started out as more of a local or maybe regional program, and we wanted to complement the services that we offer here at Nationwide Children's. It's really grown into a national and coming up soon, probably an international program where we're really trying to be thought leaders when it comes to infusing children's mental health into the conversation at all levels, starting in preschool and going all the way up through childhood and adolescence.
And can you give us maybe some background and statistics about how common mental health problems are in children? And what are some of the most common mental health concerns for kids?
Yeah, the statistic that we use is that 1 in 5 kids, and I think you mentioned this at the beginning, Angela, 1 in 5 kids is suffering from some sort of mental health condition that's impairing their functioning. And, this could be a really wide range of conditions because some of the more common statistically are things like anxiety disorders and depressive disorders. But we also would like to think that there are probably a lot of kids who haven't been diagnosed with a mental health condition, but are being impacted by mental health. And those are the kids who are really struggling in school or who have some behavior challenges at home and the parents haven't sought guidance or treatment for it yet. And so there are lots of those kids out there, and it's much more common than most people think. And, one of the most powerful experiences that I think some of the parents that I've worked with have had is when they finally open up and feel comfortable talking with people about it, they get a lot of feedback that instead of oh, wow, that's a really unique situation that you're going through. It's, I'm going through that too, or my neighbor or my cousin or whoever, I also have personal experience with that and it's meaningful to me. And so I think opening up these conversations lets people understand how common it really is.
Well, and that was something, interestingly, when we spoke before, Dr. Hoet mentioned, and it's obvious to me, but after she said it, I thought, oh my gosh, yeah. That frequently you'll get people coming into the clinic presenting these physical signs, and the work that you do, which I'll allow you to introduce because it's really phenomenal, the very unique job that you're filling in these primary care offices. Many of these physical symptoms are in fact mental health issues.
Yeah, absolutely. Were you going to say something, Parker?
No, I want you to answer that one. That's your jam.
So about, like Parker said, 4 or 5 years ago, Nationwide Children started integrating our primary care clinics. So we have 12 clinics, increasing to 14 soon, and we have 6 psychologists now. So definitely working on hiring more and more psychologists so that all our clinics are covered. Because research throughout the US shows that 1 in 3 visits to primary care providers are related to a mental health concern. So whether it's behavior or mood, or it's development concerns, a lot of the times our medical providers may not have the training or the time in their short visits to address it. And so the idea is to have a psychologist there. So when you're coming to that well child visit or that sick visit and you have that question as a parent, then we can be consulted and you get that treatment in the moment. And so as Angela mentioned, a lot of the times we have families coming in, the teen with a headache or the little one with a stomach ache, and the medical provider kind of rules out any possible physical causes, and that's when I can be consulted. And we know that anxiety causes stomach aches, headaches, physical pain, chronic pain, and so they're very much related. And so it's nice to be in the clinic and offer those services.
Yeah, that's amazing. When you said that, I was like, oh my gosh, I wanted to jump for joy. It makes so much sense to be integrating this mental health piece into those primary care clinics. So it's just a wonderful program. So you said 4 to 6, or how many? Could you give us the stats again on where and how this is being integrated?
We have 12 clinics right now, growing into 14 throughout Columbus, and we have 6 psychologists.
Okay. And there's plans to expand that, or what's the thought behind that?
Yep. The primary care network would like us in all the clinics. And so working on recruiting more and more psychologists so that we can cover every clinic.
Mm-hmm. Is that something like a 5-year, 10-year plan, or what's the time frame on that?
I don't know. That would be a question way above my head. I'm not sure what the plan is. I know we're currently recruiting, but I don't know how long it will take us to get into all of the clinics.
And you mentioned that potentially the closest one here to our area in New Albany would be where?
Sharon Woods. So our Sharon Woods primary care clinic has a wonderful psychologist integrated there.
Great. So that was out of order, sorry, but I had to kind of jump on that. Dr. Am I saying that right? Is it Houston or Huston?
It's Houston. You got it.
Okay, good. I'm gonna make sure. So we talked a little bit about, as kids are coming in, they're presenting a stomach ache or something, and there's other mental health issues. Maybe could you share with the adults what we could look for as signs of trouble when it comes to kids' mental health?
Yeah, I think there are a lot of different concerns that might lead you to think about mental health as a possible contributing factor. But as a general rule, it's significant changes in functioning for a kid. That's our first warning sign. It's usually, things that they used to be able to do or developmental trajectory that they used to be on, and now they've fallen off or they're struggling in that area. That can be academic, it can be sleep, it can be eating, it can be behavior. There's lots of different ways it might present. But when a parent comes into my office, or even friends of mine in the neighborhood who might come to me and say, man, we were going really well with potty training for a while, and all of a sudden lately it's been screaming every time I try and get them on the toilet. That's a concern to me, because it means that there's probably something a little bit deeper going on. And so, the psychologist in me wants to start asking them questions, but the friend and professional in me says, I'm not your psychologist, but here are some thoughts, and maybe you would want to talk to your primary care physician about that. But in all honesty, the thing that stops a lot of people from even considering those things is the stigma associated with children's mental health, and the fact that parents don't want to admit to themselves the possibility that their child might have a mental health concern. They would rather it be a physical condition. They would rather, many parents that I've talked to, I wish they could just take a pill for this, or I wish they did have something that they needed. So I've literally had a parent say to me, I wish this was something that they could operate on and fix, rather than confronting a mental health condition, because physical conditions are so much more widely accepted than mental health conditions for kids. It sort of absolves parents from any supposed responsibility we might have for, causing something in our family or with our parenting. And I've also heard parents say things like, I'd love to learn more about this, but I don't want anyone to know that I'm interested in this topic. They don't even want to let people know that they're interested in children's mental health, because it might single them out as, having a problem in their family. So, some of those warning signs don't occur to us. And I'm probably guilty of that too. As a psychologist, I struggle to think like one of my children might have a mental health condition, because I'm a psychologist, for goodness sake. I should be able to know these things and be able to help them. But I also have to understand that sometimes it has nothing to do with that these things are just, they're similar to medical conditions, and that they occur. And sometimes you need specific help to deal with them. So having parents enter that into their mind as a potential cause of symptoms or cause of difficulties is sometimes the first step.
I guess two-part question then. So the stigma piece, you think of the reason why so many people struggle with that is because there's some sort of ownership on the parents' part and reluctance to confront that? Or
historically, there are direct accounts of schizophrenia being caused by bad parenting. And there are scientific articles that they had written, way back in Freud's time. We're talking 100 years ago, but it takes a long time to overcome that stuff when it's ingrained into a parent mindset and into a culture of, if your children are having problems, it's either your problem as a parent or it's your family's problem. It's not biology. It's not the environment. It's not, these other things. It's taken a long time for us to swing that pendulum back to just understand that, just in the same way that parents don't cause cancer and stomach ulcers, they also don't cause depression and anxiety. But the thing that we're trying to help parents understand is that while they may not necessarily be a cause of the problem, they can definitely be part of a solution. The more that they learn, the more that they understand and partner with people who can help them get good information and reliable information, they can be part of helping with a solution. And that's what, Dr. Flores and Dr. Hoet, that's what they do in much of their profession as full-time clinicians, is work with the parents as well as the kids on, here are some things I'm teaching your child, but here are some really important things for you to focus on at home with them, and ways to structure their environment or ways to communicate with them. And so those are all really important things for parents to keep in mind.
Well, and that's something we've talked about here. We do have Ohio State mental behavioral health specialists coming in the building. We've been talking with Nationwide Children's about bringing some on site as well. And I guess that gets to the point. So if you're treating the child or you're treating a parent, it's important, it sounds like, to treat both kind of simultaneously. You can't do one without the other, maybe.
Yeah, certainly. No matter the age of the child, once they get into later adolescence, there's certainly a bit more responsibility on them. When I have a 16 or 17-year-old patient, I'm focusing a lot more energy on them and them taking ownership over things, but I'm certainly still including the parents. And the younger kids are, the more crucial parents are in that process. So, in other words, the 30, 45, or 60 minutes that I might have with someone once every week or every other week, more likely, is just a drop in the bucket of what their life is. But when parents can learn to implement these things, even in small pieces, day in and day out at home, that just magnifies any impact that we have. And so parents and teachers are our absolute best allies when it comes to children's mental health, because they spend the most time with children, daycare providers, other people who care for children. And that's why On Our Sleeves focuses on those groups significant energy, because they have a really significant influence on children.
Mm-hmm. I'm getting this question. I think it's related, so I'll just throw it out there. Is there a concern ever from a professional standpoint about maybe introducing this help at an early age or too early, or would there ever be negative connotation or implications from introducing help at a young age? Anything negative that you should be concerned about?
There is nothing that I could imagine that would be bad about learning good coping skills and building emotional intelligence and all of those things. We talk about, even at age 2 and 3, when kids are having tantrums and acting out their emotions rather than using language, it's a great time to start labeling that for them and encouraging them to start using feeling and emotion words and to learn different strategies to manage their frustration. When we think about what psychotherapy really is, when we get down to it, it's remediation of these skills. It's teaching people how to adapt to a condition that they are suffering from in that moment. And many of these skills are things that we could teach all along. We can teach anybody, even us as adults. If we think about what is a self-help book, what is psychotherapy, what is meditation and yoga, what is, anything that we would think of as adults that we help ourselves with, is really just us trying to go back and better teach ourselves to enact these strategies. And so we're trying to ingrain them and make them habits, both cognitive and behavioral habits, for kids as young as possible, because then it's just a natural part of the way that they operate. And when they do fall on tough times, because absolutely everybody will, it's not totally new to them. It's, let's go back and double down on this, ability to use mindfulness or ability to use exercise to relieve stress or whatever it might be. Much easier to do then than when they're already in a mental health condition state, or when they're in a crisis, to try and go back and teach them those things when they're in that state.
And if I could jump in just for a sec here, I was just going to add that, I always tell parents that they're the first and best teachers for their children. And whether they're intentionally doing this or not, they're also teaching their children just by their own actions. So modeling is a key learning principle. And so even with a toddler, how we talk to other individuals, how we deal with frustration, that's going to be modeled by those young children as well too. So we can't intervene that early because it's something that we're already doing. We're already teaching these skills, whether we know it or not.
So it's like a toolbox. We're filling their toolbox with language, labeling emotions, mindfulness, physical activity, modeling, all of those things.
One of the things we do in primary care is a lot of prevention work. So what the mental health team calls anticipatory guidance. So we're seeing families as early as 12 months to start talking about, as Parker mentioned, how do we respond to tantrums? How do we shape behavior? 18 months, we start talking about that toolbox, like you said, of how do we model? How do we label emotions? How do we calm down? And so it's trying to do the population health level, trying to teach parents how to prevent kids from getting to a place where maybe they would need intensive therapy services.
Yeah, that's a great point. And we talked a little bit about kind of the concept of prevention, and we were talking about if there's a pyramid of care, let's say. Could you maybe describe where the three of you fit on that pyramid of care?
Yeah, sure. On our sleeves really is what we hope is the foundation, maybe even below ground, where, it's the part that you don't necessarily see because it's really hard to measure the absence of something. So, the impact we have is hopefully on society in general long term. That's a grand thought to have, but it's what we're striving for. Um, you know, People like Dr. Hoet in primary care, they're really probably the second rung. The first rung is going to be teachers, guidance counselors, primary care physicians, people who aren't in the mental health field, but get a lot of mental health things reported to them. And so then Dr. Hoet would probably be the next rung up, which is, as she was saying, she's seeing a lot of people who haven't been diagnosed with anything yet, or might not even know that there is something to report, but that a physician or someone else, they hear something and they think, oh, that's something for a psychologist to take a look at, or they're doing the anticipatory guidance. Dr. Flores' team is a rung above that because that's kids with identified conditions that they're working on. And then, there are, depending on how you want to think of it, there are a few levels above that when it comes to the more intensive psychiatric needs of some children, crisis services, inpatient hospitalization, residential programs. Those are thankfully few and far between and not needed by the large number of children out there. But Dr. Flores's team would be, if one of my children had a mental health concern or a behavioral concern, his team is where I would hope they would end up.
Mm-hmm.
Yeah, and I would say too, even if we pan back a little bit, I think I conceptualize it similar to the RTI triangle, the RTI tiers for academics, where we'd like to have on our sleeves is that foundation, as Parker was saying, and that being something that everybody gets. And if you have any of those identified problems, those are the kids that are going to need some more intervention. So they may go to Dr. Hoet, they may go to my team as well. And then we have that third tier of interventions, which is their higher level of care for people who may need interventions multiple times per week. So if we pan back, I think that's something that we can visualize as well too.
Yeah, it feels very much like almost like a roadmap. Like Nationwide Children's has gathered these experts and developed this roadmap for families, communities, teachers to use to guide us down this path. So another question that popped up is, how do we begin to integrate this curriculum into our schools and our communities and our lives?
Well, we're already working on that in a few ways. And as of right now, we have school-based teams at Nationwide Children's. And so we do have teams of people. It's usually limited to Columbus proper for right now. There's a few exceptions, but, they have teams that go into schools and provide not only education, but also services. On our sleeves, we're trying to expand that because we realize that Columbus and the surrounding area really has this robust mental health provider system that many cities don't have. And, for anybody who's tried to seek services, it's still hard to get services around here. And I'm very well aware of that. We're all acutely aware of how difficult it is to sometimes get the services you need. But in all honesty, we have one of the best networks here in Central Ohio that they have anywhere in the country. And so that tells you a little bit about what it's like living in some of these other places. But we're trying to expand out. And so right now, really all it takes is an interested person in a school system or in a school. And on our sleeves, we've developed educational curricula that are free for teachers to download. And we partnered with this company called Young Minds Inspired. And they're really an education specialist group. And they have created these curricula for us that adhere to education standards as well. So teachers can plug them right into their curriculum planning. And they come with user guides, a letter home for parents, because we feel like that's really important. Like, this is what I learned in school today, and this is how we could continue the conversation at home. And then it has activity sheets for doing in school as well. And we've got curricula ranging from, I think the youngest for right now is grade 3, and then up through grade 8. But we have in development, we have some for the earlier grades and for high school. And then we're actually creating, I think, 5 new curriculums just this year because they've been so popular, and we secured some funding for that. So right now it's really about awareness and interest, because it's all free, and, teachers who want to make time for it, and educators who want to make time for it, the information's out there. It's just about accessing it and integrating it into your planning.
Yeah, and I will say too, we're partnering with the community, with our local well-being initiative and other mental health practitioners in the community, and we are going to be hosting the On Your Sleeves programming and the curriculum here. In fact, I mean, the toolbox that was sent to us was there are more resources in there than we would even know what to do with. It's amazing. So we're going to be bringing in Nationwide Children's and the On Your Sleeves program into our Lunch and Learns, into our Ask the Expert series, into some group sessions and things with local partners. So we are going to be integrating it here heavily. It's really, we have kind of a phase 2 approach to the NCH integration here. Phase 1 is just this prevention model where we bring as much education and awareness as we can to it. So that's really what we're starting in today, is really the first of that. So you will see that definitely happening here at Healthy New Albany, but we will continue to share the message. And I'm sure, I know there's representatives from the school on, and I know they're always interested in integrating those things where they can as well. So we will definitely be pushing it from here. And if we could, Dr. Hoet, maybe to jump into a little of the work that you're doing in the primary health clinics, maybe could you just share a little bit how often you're meeting with people? Are you working with just the family or the child? Just a little bit about your daily routine there.
I don't have a routine, which is what I love. Every day is different. So our goal is to be mostly integrated. So what I talked about earlier, families come to see their pediatrician, and any question that they have, I will see the family there that visit. Of course, sometimes we'll need follow-up. I'll give them a strategy to try, I'll give some recommendations, and then I'll follow up with a family in 2 to 3 weeks. And so we try to keep those services brief. So I will do about 4 to 6 session follow-up appointments. If the family needs something more intensive, that's when I would refer to our behavioral health system. And so my day can be very, very different. I can have a kid that's having difficulty with picky eating, potty training. It could be a positive depression screen. It could be behavior concerns, eating disorders. So it really depends on the day-to-day.
What if you could summarize? I know you see a lot of different things. Are there certain maybe commonalities, or maybe what are some of the biggest challenges are you seeing and are you facing right now?
Right now, we're seeing a lot of depression. Kids are pretty isolated. They haven't had their regular routine for almost a year now. We're seeing lots of sleep problems because, schedules and routines are out the window. We're seeing, like I mentioned, that isolation, missing their friends. And then for the kids that are returning back to school, we're seeing some anxiety now. Kids have said to me, I haven't practiced socializing. I don't know how to talk to others anymore. And so they're feeling pretty nervous. Something specific to my clinic, because each of our clinics are in different neighborhoods, different populations, but because our clinic is a high immigrant population, I see a lot of that acculturation gap. So maybe parents who are immigrants and then kids who are first generation born in the US, they have a lot of difficulty just headbutting. I want to go do the things that I see my friends in the US do, and then the parents feeling nervous or distrustful. And so helping the families communicate and reach compromise is something I do often.
Yeah, that was a really interesting part of our kind of pre-discussion, just the work that you and Dr. Flores are doing as it relates to different cultures and immigrants and language. And I would say maybe are there some cultural factors you can discuss specifically as it relates to mental health?
I think there's a lot, right? Our immigrant families can be distrustful of the health system in general. There's a lot of historical reasons for that, and also seeing us as part of the larger system, even though as medical providers, everything is confidential and we were not sharing anything about their status with anyone. They don't know that. And so there's a little bit of distrust. And then of course there's the stigma. Families feeling like we deal with it within the family. We don't talk about what's going on in the home with outsiders. Or you go to church, you go to your religious organization, you go to your community, your neighbors, your family. And so that's one of the perks of being in the primary care clinic. Again, they're not coming to see the psychologist, they're coming to see the physician. And then I just happen to be there and show them this is actually what a psychologist does, and it's safe and it's okay, and introduce a little bit of what therapy looks like. A lot of Latino families tell me like, oh, I always thought it was like straitjacket, or for people that are, they'll say for people that are loco, that are crazy. And so showing them that, as we have talked about today, it's for everyone.
Yeah, and I know Dr. Flores, maybe you could comment. You talked a little bit before about how you're meeting people where you are. Maybe could you share a little bit about what you do and talk to that point specifically?
Yeah, so we talk a lot about health equity in my team. In my team's outpatient team, we see kids 3 all the way to 18, and any specific disorder, we're going to be treating it. We treat PTSD, anxiety, depression, behavioral concerns. We see the gamut here. But one of the things that we've been looking a lot at, and a lot of our referrals are for disruptive behavioral problems, and so we're trying to. We've started an Incredible Years group. We've done Incredible Years group, which is a group for kids with disruptive behavior problems between the ages of 3 and 8. It's a parenting group. We used to do that in person. Now we're able to do these groups via telehealth, which has really increased our ability to meet people where they're at. We have families from Southeastern Ohio who live 2 hours away that previously were driving 2 hours for a 1 hour appointment and then driving 2 hours back. And that's their entire day now spent traveling just for that appointment. And so now they're able to go home, log on to Zoom or log into their appointment, and we're able to have these same meetings with them right from the comfort of their own home. And so that's been something that's been a huge benefit for us, because it's enabled us to be able to meet families again where they're at. We've had some appointments, although it's not the best, where you may have a teenager in a parking lot because they want to be away from their parent or the parents in the grocery store. And we've had 16, 17-year-olds where we have a full session via Zoom on their phone with them sitting in the parking lot, making sure that we know where the parent is at all times in case there's an emergency. But I think it's another example of using the technology that we have to be able to meet these individuals' needs at the best way that we possibly can. And so,
do you anticipate then continuing the use of that telehealth even after COVID, I'm guessing?
That is our intent, yes. And so we will continue to use telehealth well after COVID. And we used it before COVID as well, too. And that's something that most people didn't realize, is that we were offering these services, but they were for such a very, very small amount of individuals. And there were a lot more restrictions pre-COVID as to how you could do telehealth. Because there's emergency orders in place, we were able to do telehealth in a different manner. And so even after we resume some of those, or those executive orders are rescinded, we're still going to continue to offer telehealth to a wide variety of the families that we serve. And we've actually just shifted within the past week, actually. By the end of this month, we will be, any family who wants an in-person appointment can still get an in-person appointment on our team. That is something that we're doing, realizing that more people are going to want to have that connection, that in-person shift, particularly as people are going back to school.
Mm-hmm. We got another question that kind of relates to what we were talking about, the anxiety and depression, and obviously the contribution of COVID with young people. How much do you attribute maybe the increase in this anxiety and depression and so forth with social media, the use of technology? I know my kids have had way more than they probably should the last year.
Yeah, I would say that that's a huge contributor to that, because even pre-COVID, especially teenagers, middle schoolers, they're checking their phones constantly. They're on there constantly, and they're posting videos and looking for feedback. And if they don't get that feedback, that immediate feedback or reinforcement, they think something is wrong. And so you have this effect where there's that compulsive checking that can lead to, feeling bad about yourself. You're comparing yourself to others on social media as well too. And I don't use social media, but a lot of people that do use it, I'm told, right, you post pictures that are the best versions of yourself. You put forth the best, which is not always reality. And so you have these young children who may not realize that, and they're trying to compare their lives to these perfect, quote unquote, perfect lives. And that can create a sense of, I'm not good enough. There's something wrong with me. And so we do see a lot of increase in depression and increase in symptoms of anxiety with those who use social media a lot. And with people being in front of screens more often right now because of COVID, I do think that there's a correlation that's there as well too. And some of the things I've talked about with the families that I work with too is that it's okay to have your kids have more screen time right now, right? There's no real guidelines that we can base how do you manage screen time in a pandemic? The last pandemic was 100 years ago. And so we're kind of just trying as best that we can, and really just trying to monitor and making sure that screen time doesn't cause, as Parker was talking about earlier, problems with sleep, with academics, with socialization, with just physical well-being as well too. And so I do see there's a slight increase with that right now because of COVID and some of the ramifications there.
And go ahead.
I was just going to say, I agree. One conversation I've been frequently having with families is that it's not that I'm worried about the screen being harmful, but what is it about, if I'm on the screen, what am I not doing, right? And so that balance, you can use your screen, you can do whatever you want to do, your video games, your social media, and exercise, socialize, your creative activities, your hobbies. One thing I find sad often is I'll ask 8-year-olds, young kids, what do you like to do? What do you do for fun? And I often can't get an answer that's outside of something screen related, video games, YouTube, and that's it. And so that's where I encourage parents, find the balance. It's okay for them to do these things, and what else?
Right. And one of the things I've talked to families about recently too is making sure to schedule in activity time and schedule in family time. It's really easy to forget about some of those things, or let time get away from you, or say that you'll get to it. And so it forces parent and child to commit to a certain time each day that they're going to exercise, or that they're going to talk as a family. There's family media plans that I talk about as well too frequently with the families that I work with. Delineate when there should be screen-free time. So at my house, for example, none of us are allowed to use the phone or any electronic media at dinner. When we sit down, my wife and I leave our phones in a separate spot. And if my wife or I break that, my daughters will come to tell us that that's something, you're breaking the rules. And so I think that's just, we have to be intentional about it.
Mm-hmm. Yeah, Patrick, thank you. Patrick Galloway, who runs the communications for the NAPLS school system, just put in the chat, if anyone is interested, that their IT director just recorded a video for digital wellness that they launched for families and gave the link. So that's on the website, and the link is in the chat if anybody wants to grab that. Thank you for sharing that. I'm getting another question. Okay, even with the tech options available in in-person meetings with counselors, is there a population who don't have accessibility who are potentially missing out? Could the schools or local food pantry do more to help in identifying this special population? So it's really this access equity question.
This was huge last year. Our behavioral health system switched to telehealth, I think, within a week. It was just incredible. But that meant that our families had to sign up for My Chart, which is their way to access their medical record. All of that is in English. And so it was concerning for my patients, because all of a sudden they didn't have access to this My Chart. They didn't have access to the video. They didn't have access to me. Fortunately, because of the state of emergency, we were allowed to do visits over the phone for a while. But of course, that takes away a lot. So there was definitely inequities in the moment during that big transition. I would say a few weeks later, we adjusted, we figured it out, we got there, but it was definitely a big problem.
Yeah, I would agree with that as well too. Even in terms of consents and sending those out, how do you send these consents? How do you communicate this? Trying to coordinate interpreters as well too, and how many people can you have in an office at a given time? All of these things definitely impacted the ability for what I see as equitable care for families. I think we do have that figured out now, where we're able to reach a large variety of individuals regardless of where they live, their native language. I think we're able to meet people at least somewhere, because something has come up within the past year where we've had to address that issue within the service line. So I think we're learning from each other and some of the failures that we've had, and then also how we've grown since last March as well.
And I think you maybe had mentioned previously, I think it was you, Dr. Flores, that talked about maybe that immigrant or minority population would be less likely to seek mental health care. Is there a reason behind that? Is it just a cultural issue?
There's lots of reasons, yeah. And so I have two examples that I can share. One is both of them have to do with our Incredible Years parenting group. So our Incredible Years group is really effective. Over the last 4 years, I've collected this data, and we found that on average, parents see a 28% decrease in the child's disruptive behaviors when they finish the group. The problem is not everybody was finishing the group, and there was some definite racial disparities that were there. Some of them having to do with just trust of who was running the group. And so, for example, I can show you really quickly here some of what this data looks like. Let me just share this here. So as you can see, this is a completion of people who completed the group, and there's 1,500 participants in here. And you can see that for white families, nearly a quarter of them finished the group. But if you look at Hispanic, African-American families, that number is much, much lower. And so we started to dig into this data a little bit more and try and figure out what was happening. And so we asked some of these families, and I asked some of my clinicians who were Black as well too, saying if you were in this group, what the problems were. And the problems were our group leaders were not diverse. And so there was just the optics of having two white women teaching a single Black mother, for example, how to parent their child. And they didn't trust that. There was this historic distrust of the mental health care system, or the healthcare system in general. You're trying to tell me that I'm doing something wrong, right? There wasn't rapport that was established as well too. And these families, because there's that distrust, they took longer to gain that trust. There's also transportation and childcare barriers for these families as well too. Being able to take time off of work, get to these appointments. Those were all significant barriers that just led people to, even if they wanted to stay in the group, they couldn't because they dropped out of it. And so we try to address these by making sure that now we have at least one clinician of color co-leading the group. We also, for families that would like it, offer a second intake session to make sure that we can establish that rapport, establish that trust when we get to that next group. And we've also provided, we've received funding for bus and cab vouchers as well to provide transportation to and from. So that's one example. But another example that I can share here as well too has to do with our Asian population. I know New Albany has a significant Asian population as well too. So I thought that this would be pertinent. We know that mental health affects all races, cultures, socioeconomic groups, but not all seek services at the same rate. And so there could be a lot of reasons for this. And one of the things I've done is compared US Census data and the demographic data of patients that we see in the clinic. And so is each group being represented similarly to the distribution? And so, for example, 39% of residents of Franklin County identify as a racial minority, yet only 28% of the families presenting to our outpatient therapy visits in 2019 identified as a racial minority. That's an 11% gap there. As you can see in this graph here, the green represents the Franklin County census data, and the blue represents the referrals sent to our outpatient team in 2019. You can see the white grouping here is very similar. You can see Latino is also pretty similar. And then we get to Black, and it's a greater disparity. We get to Asian, however, and it's a huge disparity. So 5.7% of Franklin County identifies as Asian, yet only 0.5% of patients presenting to outpatient therapy in all of 2019 in Nationwide Children's Hospital identified as Asian. That's a significant difference there. And so we dug into what the reason for this was. Are individuals, are Asian individuals not seeking care? Where are they going if they are seeking it? What are some things that we are doing or missing here? And so I had a clinician on my team who's Chinese, and she pulled some of the individuals that she knew within the greater Columbus area that were also in the Chinese population. And so what we found is unexpected, at least to me, as someone who grew up born and raised in suburban USA, which was these families often avoided seeking mental health concerns until it was something like schizophrenia. That's when we should go see somebody, when it was so significant that we couldn't deal with it within our own home. The other was stigma. Stigma is still very, very strong regarding mental health in the Asian community. And oftentimes these families lived in intergenerational households where you may have a younger generation wanting to seek care, but you have the older generation, the parents, who are really, patriarchal, matriarchal figures within the home saying you shouldn't do that because essentially you shouldn't air dirty laundry out. You should focus on what we have here, try to deal with it on your own. There's also the distrust of the American healthcare system. Also just confusion as to how healthcare worked in the United States. Most of these families, even though they are very, very educated and a large variance in terms of their socioeconomic status, didn't know that insurances covered mental health care or how to even access mental health care. They didn't know numbers to call or how to get an appointment. Another point that I thought was big too was communication, and not just linguistically, but also culturally. So these families said they wanted somebody who knew their culture so they could talk to them about the unique experiences that they're going through. So for example, if you have a Chinese family and they're trying to seek some of these, they're in an intergenerational household and they're trying to seek these services to treat their child's disruptive behavior problems, that's going to look different because they're going to have to confront potentially their parents and their parenting strategies. And so having a unique cultural perspective was key to these families. And so they thought that quote unquote white people wouldn't know what they were really going through. And so they didn't seek services until they got to somebody who they felt really understood what it is that they're looking at. And so for me, I've really learned over, with these experiences, a health equity isn't just do people have equal access to care. It's really an effort by all of us to ensure that people know how to seek these services and that they trust the services that's available to them as well too. I'm sorry, that was a very long answer to your question.
No, that was excellent, and thank you. And I think that's an excellent point, that it's not just equal access. It's a host of other things that create that ability to seek and receive care. So that's really important. Thank you. And even just for us here, as we're developing connection points in the community, having that diverse leadership makes a huge difference. And even for us who are kind of in the public health field, it's good to be reminded of that. I think it's really important. At the food pantry, I know, and thanks to the Wellbeing Connection, we have started some online telehealth group sessions with some of our families and had a Spanish speaking therapist be able to assist them. And I think those are the little beginnings of just that, ability to create that connection point and provide access to people that don't know how to get it or don't know where to get it or can't afford it, and all of those host of things. So thank you for that. Dr. Hoet, any other additional, were you wanting to jump in on there? Sorry, I saw your screen buzz.
Oh, I was just clapping because that was an excellent point, all those points that Dr. Flores shared.
Thank you so much. Well, and that's something we've been talking a lot about here, and I feel like it's probably a drum we're going to keep beating, but just the concept of the social determinants of health, and sometimes why your zip code can matter more than your genetic code. If we could just take a brief moment to touch on the social determinants.
Yeah, that's very important. We just had I wish, Parker, that we had access to these slides, but we had a slide shown to us of the zip codes of Columbus. And there can be a 30-year difference in life expectancy depending on what zip code you live in. And that was pretty shocking.
Yeah, there's, the research here in our own backyard is pretty jarring to see. You hear about these things as a theory, but when you see it applied to your own neighborhoods and you say, "Oh, I drive down those streets and I know where these places are," and then you think that you look around and you're seeing people who are having a very different life experience when it comes to health and medical care and community support than you might be in your neighborhood. It's a pretty jarring thing to realize. And what we mean when they say that your zip code can determine your health outcomes, it's certainly not just one thing. It's not just how many doctors live there or how much money people in that zip code make. There are a lot of different factors that contribute to, nutrition in your neighborhood and education in your neighborhood and, the ability to travel, to seek higher levels of care if necessary. Dr. Flores was talking about how telehealth has, been, for some of us, it's really been a silver lining that it was propelled forward so quickly this past year that we sort of were forced to develop technologies and change laws within a short period of time. When else does a law like that change in a month or two other than in a situation like a pandemic? And so, the clinic that I work in is deals with medically complex children with feeding conditions and developmental conditions. And so we have kids who would have to fly in from other states to do an evaluation or would have to drive from surrounding states because we have a specialty clinic that covers a good portion of West Virginia, Kentucky, Indiana, Ohio, a little bit of Pennsylvania. And so, as Dr. Flores was saying, you think about someone who has very limited resources going on a 6-hour drive for an appointment. It's a pretty taxing thing on families. So all of those things go into these social determinants of health, in addition to, what stories that Dr. Flores and Dr. Hoet can tell you about personal families, and how culture impacts and the expectations they have of who they're interacting with and some of the experiences they have with actual providers and actual clinics as well. So it's a systemic problem that each of us, each of the three of us in our own small way are trying to impact this system that is really huge and involves way more moving parts than any one person can really comprehend or try and operate on. But we try and pick out an area where we think that we can make a difference for a group of people or for a mentality or something like that. And we try and move the needle a little bit and hope that there are lots of other people doing the same thing.
Mm-hmm. Absolutely. Go ahead, Dr. Hoet.
I was going to add, we know that stress really has a strain on our physical health, right? And so we have families who are constantly under chronic stress. They're facing racism, they're facing discrimination in every single part of their life. And it causes what's called the weathering effect. And so over and over, their bodies are just being broken down. And that's why we see that difference in higher incidence of mental health disorders or physical health. And so again, another reason that I love to be in the primary care clinics is that it does give me access to the populations that may be facing this racism or discrimination. And but like Parker said, sometimes it feels like we're putting in a little grain of rice into this whole very large system that's impacting them on the day-to-day.
But so important because, as we all know, just those little ones add up, and at least we're impacting those ones and twos every day for sure. That's where it's at. Thank you. We did have another question come through related to cognitive behavioral therapy. Has become the predominant emotional care treatment for a number of mental health conditions that children and adolescents are experiencing. Would one of you describe cognitive behavioral therapy and share what kinds of conditions and situations where you would routinely use this?
Mike, I feel like this is your alley.
Sure. So CBT, cognitive behavioral therapy, focuses on two things. We have the cognitions. So oftentimes we have automatic thoughts that people have. So, you know, I'm going to fail this test, right? I'm going to fail this test. I'm going to be not able to get a good job, and I'll be living in a van down by the river, right? That's something that would be some of those cognitions that you may face. The behavioral parts as well too. So the behavior part is doing things that show that that's not actually going to happen. So we see this a lot with anxiety treatment. So we talk about how your thoughts, feelings, and behaviors all interrelate to one another. The example that I give frequently is imagine that you're racing up 10 flights of stairs to the top of a building, right? You get to the top of the stairs, and then your heart is just beating, you're sweating, your hands are clammy, and you can have two different ways to react to that. You can have one reaction, which is, oh my gosh, I'm dying, I'm having a heart attack, this is the worst thing ever. I think I'm going to die, I need to call 911. Another thought would be the exact same symptoms. You have the racing heart, you have the sweaty palms, but you can think, oh man, I really need to get in shape. So just the way of changing how you think about it changes how you react to that situation as well too. And you know, when we think about anxiety, we have kids rate to themselves, what do they think is going to happen when they go into this situation? When you talk to this stranger, what do you think is going to happen? I think this person is going to think that I'm a horrible person, and they're going to tell me that, and all of these, you know, faulty cognitions. And then we say, okay, well, let's go ahead and try that. And then 99% of the time, it's okay, and it works out fine. And so we poke holes, you know, in that faulty thinking. But that takes a lot of effort to do that. And one of the things I tell families too is that imagine you have a cup of clear liquid, and then you put one red dropper of food coloring in there. That's going to color that entire liquid now. So now it's pink. How much more clear liquid or positive experiences would you need then to dilute that back to clear again? And that's why when we do CBT, we have to do these exposures, and we have to challenge these cognitions over and over and over and over again, because it's hard to do that. And one of the key things that, you know, I think sometimes it's hard to get across is that we're not going to necessarily change the cognitions that you have. We're going to change what you do with those cognitions. You may always think, you know, this is going to be a scary situation, but does it impair what you do next? And so that's kind of the basis of CBT. And CBT is really great for particularly adolescents, kids that have the cognitive ability to be able to have some sort of introspection. It's not as great for some of the younger kids who just don't have that ability developmentally yet. And Ariana, I'm sure you talk about this probably every single day as well too.
I love that clear water example. With CBT, I think there is a lot of evidence behind it. It is what I use the most. And at the same time, with immigrant families, I have to be really careful with it. A lot of the ideas behind CBT is, as Dr. Flores explained, there's these automatic negative thoughts, and we call them distorted thoughts in cognitive behavior therapy. And a lot of the times our families that are going through real life stressors, it feels really weird to tell them, you know, how can you think differently about that situation? What's the positive thought? And so it can be very dismissive, especially coming from me, the privileged white person, telling this family, you know, let's challenge your negative thought. And so while the theory behind it is what informs my practice, sometimes I work more in the behavioral changes and how do I cope. Like Dr. Flores said, you're still going to have these cognitions. The stress is still going to be there. What do you do with it? How do you cope with it? So I focus more on the behavioral part of CBT.
We had another question just about behavioral problems and how to, as maybe some ability to discern if something is just a phase or just someone acting out, as opposed to an actual concern that we should take action on.
Yeah, so that's something I see all the time. And the first thing I'll say is average compliance is only around 70%. So if your child is compliant 70% of the time, they're doing great. So that's just for context. I think the things to look out for are, do these behaviors go across multiple settings, across multiple individuals as well too? As a teacher having the same problems that you're having at home, have you tried some behavioral interventions and nothing just seems to work? Is it impacting them socially? Is it impacting them emotionally? Are they having self-esteem issues as well too? Those would be things to be on the lookout for. And oftentimes, we run into families that are doing everything perfectly, and it's just kind of normal non-compliance. It is also normal for kids to have that autonomy or that desire for autonomy. So we need to think about that. And think about what parents are doing. Are they modeling some of these same behaviors as well too that they don't want to see? Are they, reinforcing inadvertently some of these behaviors? And one of the main principles with behavior therapy is something called the attention principle, which is if you give something more attention, it's going to happen more frequently. If you give something less attention, it's going to happen less frequently. The problem is with disruptive behaviors, we give that a lot of attention. And so we're inadvertently making the situation worse when we really should try to be ignoring that. But then ignoring is also hard to do, and there's a certain way to do that as well too. Are we giving too many commands? On average, kids get 15 to 20 commands every 30 minutes. And I tell parents, imagine if your boss was giving you 15 to 20 things to do every 30 minutes. Would you be a happy camper as well? I know I probably would just be a little bit non-compliant just because if I was getting that many commands. So just trying to put parents in their children's shoes a little bit as well too, but they can always come to us and ask those questions as well too, and consult about some of the issues or concerns that they're having.
Thank you for that. We have a couple other questions, and this one we could spend a whole 2 hours on, but just the concept of addiction. We know that there's a big issue in many communities. Ours is not exempt, with some addiction issues as that relates to kids and parents, but kids here today speaking with you. Can we speak just a little bit about that?
Well, I mean, none of us specialize in addiction. Addiction is a really, it's a specialized concern that many times you go through special certification and special training to become trained in how to manage addiction. Nationwide Children's doesn't have many providers who specialize in addiction. And actually, we don't have an addiction program specifically. We do have some programs that, might address addiction as part of treatment, but it would usually be in cases where there's not, an active use case going on that's impairing their ability to participate in treatment. Because what we know is that addiction is just sort of a whole different type of mental health and behavioral health concern than many of the things that typical child psychologists deal with, because it's a chronic issue. As they say, addiction is not a I have it and now I don't have it thing. It's I suffer from addiction and I am experiencing an addiction problem, and that's something that's going to follow me for the rest of my days, and that will need, constant management and will be a difficulty for me. So it's similar to eating disorders in a lot of ways, where eating disorders is another thing where we have a special clinic at the hospital because eating disorders are typically diagnosed in childhood and adolescence for the first time for many people. And so if any of us were to receive a referral for someone with an eating disorder, all three of us would refer them to a specialist provider if possible. Now, that's not always possible, and sometimes we have to try and manage it. But addiction really is one of the biggest challenges facing a lot of kids in our country and a lot of adults right now from a mental health standpoint, in my view. And I think a lot of people share that view, that the lack of reliable services and treatment options and the cost for those services is really staggering. So it's difficult to find a reliable place once a child is suffering from addiction in that moment. It's sometimes hard to find a reliable place to send them because there are plenty of predatory clinics out there that charge a lot of money and don't have great outcomes and don't have great staff there because it's such a difficult thing to manage. So I wish it were different and that we had really great evidence-based treatments and things that work long-term. But the reality of things is prevention is the absolute best solution for drug use and for addiction, is hoping to teach people better coping strategies to prevent them from using drugs, to prevent them from falling into that pathway. So I know that's not a fun answer, and I don't like having to give that answer whenever I'm asked about it, but that's the reality a lot of us find.
Well, I think it speaks directly to the power of prevention. I mean, it just makes it so clear that what we're talking about today, we really need to understand and incorporate and share so that we can, be a preventative mechanism for, to guard against that. So I guess that's the last 15 minutes, which is always my favorite because it's an opportunity for us to kind of summarize the takeaways and discover what tangible actions we can take. So I was just jotting down a few notes kind of for us to take home as our toolbox. If I could rattle a couple off and then maybe fill in the gaps so we can, I need lists to function. So my checklist for how to prevent and add, wonderful mental health guidance to my family and community would be, here's a few. Physical activity, keeping your kids active, balancing the screen time, providing language and learning opportunities, adaptive skills, decreasing the stigma, scheduling family time, modeling these good behaviors for our kids, incorporating mindfulness. What else? What else can we add on to that list?
I would say, a theme that undercuts pretty much everything you just went over is having an open line of communication about all of this. That, one of the best preventative measures for lots of these conditions, drug use and addiction included, is having open conversations about it. And so as parents, our instinct sometimes is this topic is scary, or it's embarrassing, or it's something that I don't think applies to my child because my child isn't that kind of kid. And so we just don't really talk about it. And we just say, well, if I sign them up for soccer, or if I make sure that they're playing the flute, then I'm doing my part to get them engaged. But it's really more than that. It's about discussing, the role that those strategies play in leading a healthy lifestyle, both physically and mentally, and that it's a purposeful thing. It doesn't happen by accident. So, when it comes to parents, teachers, and other people who work with kids, being able to talk about these topics, finding a way to make it normal and okay, to provide them with not only, here are some things to look out for, but let me tell you what to do instead. Let me tell you some good things that really work, that we know are helpful. That to me is one of the most crucial things that every single person could do with every single kid out there, no matter who they are or where they live.
And what does that conversation sound like with an 8-year-old, with a 14-year-old? I mean, what are you saying to them?
Well, I have an 8-year-old and a 5-year-old, so I can tell you what it sounds like in my house, but my house is probably a little unique. What it sounds like is, first of all, it doesn't have to be doom and gloom. You don't have to come in with, I want to sit you down and talk about addiction today, or let's talk about depression. It can be just opening up about, tell me about your day. And when they say, yeah, fine, then follow up with, what was the best thing that happened today? What was something you did lately where you felt really successful, that made you feel really proud of yourself or really happy? who's your best friend at school? Why are they your best friend? And what does it mean to be a good friend? And then, once they get used to talking about some of this stuff and thinking about it a little bit more deeply, then you might start asking them things like, what's been the toughest thing this week? What's a time when you really felt like you didn't have it together lately? Or, what are times that you can remember feeling really sad or that you needed to talk to somebody? And who would you talk to if you needed to talk with someone? There are so many different questions. And at onursleeves.org, we have a whole list of conversation starters about mental health, about school, about all kinds of things, because we realize that it doesn't come naturally to a lot of us. It's not typical conversation. So we have lots of conversation starters and questions to ask and things like that.
And those are on the website. Is that right?
Yeah. Yep. At onursleeves.org. And it's one of the things that you can't avoid on there, because we put it in several different places, because we feel like they're mental wellness tools, but they're also advocacy tools. I ask my friends' kids too, how's your day going at school? Like, what are you thinking about this learning at home stuff? What do you like about it? Is there anything that's great about it? And what's the hardest thing about it? And then I watch their parents listen to the answers, and they're like, I had no idea about that. It's like, well, yeah, because you didn't ask, and so we can be models for even our friends and our colleagues and things like that, it's okay to talk to kids about this stuff. And if you get a surprising answer, explore it a little bit more, and then talk about it with people who you trust to give you good advice.
I had a therapist once tell me, and I thought, really? Is that true? And sure enough, I tried it, and I was like, that is magical. He said there are certain windows of, I don't know if he called them windows of opportunity in a day, where kids are more prone to perhaps say something to you. Like he said, maybe when you're riding in the car with just that child and there's nobody else there, or at night before bed, you're laying next to them and just there's no other distractions. And there are those windows of communication that kind of magically appear. So he said, just kind of try to begin a conversation when you feel one of those windows of opportunity. And it was like unbelievable that is a thing. There are those windows that happen that provide you that discussion point.
Yeah, definitely. And making it a routine too is really the best way to do it, because, we all have habits, right? We do the same things day in and day out. And when our habits just get disrupted, we form new habits. And sometimes you have to be purposeful about including the ones that force you to stop and put everything down and really take time to listen or think or have a conversation. Because if you're not careful, like Dr. Flores was saying, those times pass. We can fill all of our day with worries, stressors, work, cleaning the house, preparing meals, doing laundry, all of that stuff. That can certainly take up all of our time and energy. So as frustrating as it is, sometimes we have to say, this is the time where I'm just going to put my phone down and I'm going to stop doing this other stuff, and I'm going to really talk with my family. And when it becomes a habit, then everybody will do it, and they'll remind you if you forget, or they'll start volunteering things, So, my time is like before bed. I'm the bedtime guy at my house, have been since my daughter was born 8 years ago. And so that's my time where it's like, we're reading books, but I'm also talking with them about their day, what they're looking forward to tomorrow, what they're thinking about something upcoming. And I've just made that a habit for myself, and that works for me because I know it's consistent for me.
We had another question about books, whether that be children's books, also books for adults, but things that we could read to our kids, elementary and middle school kids, to kind of facilitate this.
Yeah, I was trying to type something in there really quick to answer, but I'm happy to answer out loud too. There are two organizations that I would suggest looking into, because there are so many of these great books out there that there's no way that any of us could keep up with all of the great ones. So one of them is a local organization called Harper's Corner. And if they haven't partnered with New Albany schools yet. They're probably looking to sometime soon. And Dr. Hoet is involved with them. They got in touch with me through On Our Sleeves, and then I thought some members of our diversity and inclusion committee would be really ideal people to partner with them. So what they do is they donate books like that to schools in Central Ohio. And so they have this whole system where they vet these different books on emotional development, and there are other topics too, but they have a good diversity representation to their books as well. And so that's a local organization. A national organization, which is similar, is called First Book, and they have a similar mindset, but they focus more on under-resourced, low income areas primarily, but they partner with lots of people. And the reason to look them up is because they have a great list on their website of books that cover a wide variety of topics. So you can search by topic of, I want to learn about emotional development today, or I want to learn about emotions today, or trauma, or resilience, or whatever. And they have great lists of books that they keep updated. And so I actually personally go there if I'm looking for a book, like what's new that's out on this topic that I could read to my kids or recommend to a parent. Those are both great ones that I know of.
And this is not a book specifically, but Sesame Street has a website called Sesame Street Communities. I'm putting it in the chat. It's all evidence-based, and you can find anything: emotion regulation, bullying, divorced parents, really anything. So a lot of the times, of course, it's for kids. I think 0 to 10 is what they have here on the website. But they have it so that you can pick it as a teacher or as a parent, and they have really good resources on there.
Last question, and then we're going to wrap up. In 10 words or less from each of our physicians, what is the single most important thing we can be doing, whether that's as parents or community members? 10 words.
Okay. Talk with your kids. I'll keep it to 4.
I love it.
I got a 5-word one. So create a sense of hope.
I'm going to go with Parker on this one, but a little bit different, and reflective listening. So truly listen to what they're saying.
I'm writing this down. Yeah, that was interesting. Dr. I want to say Ackerman. Yes, NCH physician, Dr. Ackerman. That's what he said. His single most important thing was validating them. Whatever that is for that child, just validate them and make them know that they're worthy and valuable. So, well, I can't thank you enough. This was wonderful. I'm glad to say we have more conversations planned. So I will definitely look forward to those in the future. We will send out some information that we talked about today, so we'll blast that to our list. We have some upcoming Lunch and Learn topics to make note of. April will be human trafficking. We will be talking with Grace Haven and our police chief, Jones, here, as there was an incident recently, so talking about the awareness even in our own community. May, we'll talk about veterans' health. And June, we will discuss cultural humility and race as a public health crisis, back with Dr. Oliawala again. So those are our topics for upcoming Lunch and Learns. Again, we will be working with Parker and his various team members to bring this On Your Sleeves program to the community, whether that's through the school, certainly here at Healthy New Albany. We're going to be pushing as much of this information out as we possibly can. If you have questions or you have other topics that you would like to see, please reach out and let us know. And I just can't thank you both, all of you, 3 of you, enough for your time today. It was really great.
Thanks for having us.
Invitation.
And thank you for the work you do in our communities. That's really wonderful. We'll see you all soon. Thanks everyone for joining.